veterinary medicine. He received his veterinary degree at the University of Dublin, and did a rotating internship at the University of Sydney. He is a diplomate of the American College of Veterinary Internal Medicine, Cardiology. Did go to veterinary school at the University of Virginia. His current interest, or his interest in cardiology, is advanced cardiac imaging techniques, cardiac surgery, congenital cardiac diseases, interventional cardiology, and veterinary education. Again, thank you so much, Dr. Aherne. As we wait for others to log in, you can go ahead and get started, and we'll get the late stragglers in as they come in. So take it away, Dr. Aherne.
Brilliant. Thank you very much for that introduction, Herdist. I'm going to try and keep an eye on the chat. If anybody has questions throughout the webinar, certainly feel free to pop them up in the chat, or just to unmute yourself and ask, and I will certainly try to get to them. So as we move on, just a brief overview for what we're going to talk about tonight. And so, I know we're specifically, kind of looking more towards ER and ICU kind of ECG interpretations. However, that's even in that setting, ECGs are applicable to all settings, and so it's going to be a somewhat of a broad overview of arrhythmias overall. So we're going to look at some of the basic principles of how the cardiac action potential and the surface ECGs are generated, look at interpreting the ECG itself, the mechanisms behind how some of these arrhythmias develop, look at specific antiarrhythmic drugs and their mechanisms of action, and then look at some specific examples of arrhythmias. So it'll be kind of we'll kind of approach it with a kind of a what's your diagnosis, where I'm just going to give some ECGs, and we'll see what your thoughts are, and then we'll go through the actual diagnosis. So starting off on some basic principles, obviously a lot of this is going to be nothing new to you all. So our signal is going to get started in the sinoatrial node, and that's going to cause a stimulus that's going to cause the atria to contract. Now, we're not going to see the sinoatrial node itself on the ECG, but we will see the atrial contraction as the P wave. And then that wave of depolarization is going to spread across the atria, and once it reaches the AV node, it's going to get delayed in the AV node before then the signal being transmitted down through the right and left bundle branches to terminate in the Purkinje fibers, which will then cause depolarization of the cardiomyocytes themselves. And if we look at the actual electrical potential in these cells, it can vary depending on whether we're looking at atrial cardiomyocytes, like this example down here on the bottom, versus ventricular myocytes, which is up here at top. And this is kind of the classic action potential that we usually describe. But it's particularly different when we look at the sinoatrial and the AV nodal tissues. So these are kind of specifically pacemaker cells, and these are very unique in that they can generate their own, I guess, depolarization impulse. And so the shape of the action potential is going to be very different in them. So when we talk about the action potential itself, typically it's described as 4 separate phases. And instead of starting off at phase 0, we're going to start off at phase 4. So phase 4 is essentially the resting potential. So it's going to be typically about minus 90 millivolts in the majority of cases. And then once we get an action potential being generated in the ventricular cells at least, then we've got phase 0, which is that really rapid upshoot, almost vertical upshoot. And then as we start to get repolarization, we'll get opening of potassium channels initially, which will cause this little peak, and then we'll get opening of calcium channels, which will continue this kind of plateau here before finally it drops down as we get more and more potassium channels opening to get back down to phase 4 again. And that pattern is quite similar in atrial tissue. Again, we still have phase 0s, 1, 2, 3, and 4. And then when we look at the sinoatrial node and AV node, then things get a little bit different, where we have a phase 4, but instead of being a flat line as it is in the other cardiomyocytes, it gradually increases. There's a slow inward influx of sodium that gradually brings it up to threshold, and then at threshold we have another phase 0 where it jumps up. Sometimes it can be a little bit more gentle of a slope. This is due to calcium channels this time, and then we get repolarization again through potassium channels. So these are typical phases that we think about when we look at the individual cells. And why do we really care about that? Well, we care about it because of the what's happening at each of those phases. So, you know, phase 4 is going to be when there's not a lot happening. There is an inward rectifier current, which is mainly going to be some influx of potassium, and that just keeps everything at that kind of, you know, negative 90 for the most part. Once we get an electrical signal going to the myocyte, so once the signals travel through from the SA node down to the AV node and down to Purkinje fibers, then we'll get stimulated into phase 0. And so we'll get a rapid influx of sodium through the sodium channels here, which will give us a huge positive upward stroke. And then we have this overshoot period at phase 1, and the kind of overshoot is because the sodium channels go straight up and then they stop all of a sudden, and then we're going to get some potassium and a little bit of chloride out, which is going to bring this dip down. But then we start to get some calcium coming in a little bit after this, which is what results in this kind of plateau here. And so it's a little bit slower and it keeps that kind of positive influx into the cell. And then finally, those calcium channels will close, and the potassium channels are going to be predominantly in charge, and we're going to get an efflux of potassium until we get back down to that resting membrane potential. And so by having an idea of what the different ions are doing at the different phases of the action potential will actually help target our treatments later. Again, here we're kind of looking at a similar thing, but in the pacemaker cells, and like I say here, it's usually sodium and a little bit of calcium that's causing a slow upward slope to phase 4, and then we get phase 0 here is going to be predominantly all calcium channels. And then we get potassium channels causing efflux again to get us back down to our phase 4 again. This diagram here helps to kind of demonstrate a little bit better if you're kind of like me and more visually oriented. And so again, when we're talking about sodium, we're mainly talking about phase 0 when we talk about the cardiomyocytes. So specifically, we're talking mainly about the ventricular myocytes, but also the atrial myocytes to a certain degree. Whereas when we look at the SA node and AV node, then it's really only affecting the kind of the resting membrane potential and has very little effect on the actual action potential itself in those cells. So sodium channels are going to be way more important when we look at the individual cardiomyocytes. Potassium channels are going to be very important in both cases, okay, particularly because they get everything back down to phase 4 again. And we see that here again in green. And our calcium is going to be important in these red sections here. So it's going to be very important when we're looking at SA node and AV nodal tissues, because it's going to be the main component of the upstroke of the action potential. And it'll also have some importance in the cardiomyocytes as it contributes to that plateau in phase 2. Again, here's just another example showing that in another bit more detail in the SA and AV nodes. So when we look at the ECG itself, what is it? So the surface ECG that we look at and that we'll take a recording of, it's essentially the sum of all the electrical activity from all the individual cardiac myocytes within the heart. And so, you know, the different waveforms we're going to see are going to reflect different portions of depolarization throughout the structure of the heart itself. So like I said earlier, when the SA node itself generates an impulse, we don't see that on the surface ECG. It's too small of a signal to be detected. But we do detect a P wave, which is the depolarization of all the atrial cardiomyocytes in response to the firing of the SA node. And then, so that's going to give us this deflection here. And again, I'm not going to have to kind of explain too hard the P wave, QRS, and T wave, but we're more so going to talk about how they get generated. Obviously, we're then going to have a PR interval, and that reflects the time pause that occurs at the AV node. So the signal hits the AV node, and the AV node is the great gatekeeper to the ventricles themselves. So it causes the signal to pause for several, 60 to 70 milliseconds in order to allow complete emptying of the atria before the ventricles then start to contract. So it's a very important section of the cardiac depolarization. Then we get our QRS complex. And again, it's very much a complex. It can have widely different appearances depending on what's going on. Normal animals won't always have a Q wave. A Q wave is the first negative deflection after the P wave, and not all animals will have it. Some animals go straight into an R wave. Again, an R wave is the first positive deflection after a P wave, and not all animals will have that. Some animals might just have an S wave. Okay, if they have a right axis deviation or a right bundle branch block, they might not have a Q or an R, might go simply straight to an S. So it's very much semantics, what portion we'll call Q, R, and S, depending on what lead that we're looking at. And that's why I think it's better to just refer to it overall as a QRS complex, and then look at the whole thing as being either predominantly positive or predominantly negative. And we'll talk about that a little bit later as we talk about interpreting the ECG. Then we're going to get an ST segment, which again is just the time between the end of depolarization and the start of repolarization. And repolarization is going to be reflected on our ECG as a T wave. Now, the T wave in our domestic species, in cats and dogs, can be variable in polarity. It can be positive, it can be negative. It doesn't really matter. What matters is if it changes in any one animal, as you're watching it. So it can vary quite widely amongst animals, but within one animal, it shouldn't change. So how are we going to apply the ECG itself? So I guess, before we start interpreting arrhythmias, we really need to know the strengths and weaknesses of the test that we're using. And so we can use it to diagnose cardiac arrhythmias. That's the most important thing that we're going to assess with an ECG. We can also potentially identify certain metabolic and acid base and electrolyte changes, which will result in certain ECG changes and certain arrhythmias. We can use it as a monitoring tool in patients that we have started on antiarrhythmic therapies to see if they're responding to therapy, if there's been a partial response, maybe we need to adjust the medications, and even looking for additional arrhythmias that we might be causing with certain therapies. And we can potentially use it as kind of an adjunctive method for detecting chamber enlargement. Okay, and we need to be aware of the limitations in that it's only effective at identifying chamber enlargements in about 60% of cases. So about 40% of the time it's going to miss some subtle enlargement changes, and it's never going to compare as well as doing direct imaging, such as doing thoracic radiographs or doing echocardiogram. But when there are changes present on your ECG, then that's usually fairly specific for ECG or for chamber enlargement. So interpretation itself, I guess ultimately it always has to have kind of a systematic approach. It doesn't necessarily matter what order you approach it in, so long as you approach it in the same order each and every time to avoid missing any steps that would lead to an accurate diagnosis. So typically what I do first of all is just calculate a heart rate, and we'll talk about that in a little bit more detail shortly, but essentially we've got a couple of ways of doing it. So we can do either an instantaneous method or we can do an average method. So the average method, we can count out over 3 seconds or 6 seconds on our ECG, and that's going to depend on our paper speed, whether we're using 25 millimeters per second or 50 millimeters per second, and then depending on, if we count over 3 seconds, we count the number of complexes and multiply by 20 to get the rate per minute. And the same thing if we're doing over 6 seconds, then we can multiply by 10 to get the rate per minute. Alternatively, we can do an instantaneous method where we simply count the number of 1 millimeter boxes in each R2R interval. So these small boxes here, we count the number of those between each QRS, and we just need 2 QRSs to do that. And then depending on our paper speed, if our paper speed is at 50, then we will divide 3000 by whatever number we get between those R2R intervals, and that will give you your rate per minute. And alternatively, if we're at 25, then we're going to divide 1500. After that, we'll look at the rhythm overall. So just kind of touching a little bit on paper speed, there's a couple of quick and easy cheats, because if you're in an emergency or ICU setting, you don't necessarily have time to sit down and count all those little 1 millimeter boxes. So we got to make it a little bit easier for ourselves. So one of the easiest ways that a lot of you have probably heard of is the pen method. And it specifically has to be a big pen with the cap still attached. Okay, and so that works out to being exactly 15 centimeters or 150 millimeters. And so at 25 millimeters per second paper speed, that 150 millimeters is going to be the equivalent of 6 seconds. So you can simply lay your pen down on your ECG, and you know that that's going to be covering 6 seconds, and you can count the number of complexes in that time period and multiply by 10. Additionally, if we're at 50 millimeters per second, then that 150 millimeters is now only going to be 3 seconds. So we're going to have to multiply by 20 to get that rate per minute. And another thing that's really helpful, which I didn't really learn until relatively recently, is that tongue depressors are exactly 15 centimeters as well. So if you don't happen to have a big pen lying around handy, you'll hopefully have a tongue depressor in your clinic. So again, here's just an example of, you'll have your ECG paper, you'll put your pen down against it, and if you're at 25 millimeters per second, then you're going to have 6 seconds worth of recording. Whereas if you're 50 millimeters per second, this time period is only going to be 3 seconds. So when we look at the overall rhythm, we first need to identify the individual complexes. So we're going to look for P waves. We're going to look at their configuration. Are they positive? Are they negative? Are they all the same? Are they changing a little bit? We're going to look for QRS complexes, and we're going to look at basically all the same things. You know, do they all look the same? Do some of them look different? Are they occurring regularly or irregularly? And what's really important, particularly for identifying if arrhythmias are supraventricular or ventricular in origin, is to look for an association between P wave and the QRS. So supraventricular arrhythmias are pretty much always associated with atrial depolarizations, and so there should be kind of a fixed PR interval. It's just not always apparent because the P waves might be hidden in the preceding T waves. Whereas when we're dealing with ventricular arrhythmias, there's no association between P waves and QRS complexes. So the P waves that you do see do not have any fixed relationship with the QRS, with the abnormal QRSs that are present. Again, if it so takes your fancy, you can then sit down and measure the amplitudes, durations, and all of those on lead 2. Again, not really applicable to an ER setting. You're not really going to have time to sit down and do that. But you can if you need to. That'll be more so when you're wanting to look at chamber enlargement patterns and things like that, which again are going to be superseded if you have access to doing a TFAST or taking chest x-rays or anything like that. And then you can determine the mean electrical axis, which is kind of a quick and dirty method of perhaps giving you an idea if certain chambers are enlarged. And we'll talk about that in a little bit. So looking at the mean electrical axis itself, when we think of the electrical depolarization that we see on the ECG, be it P wave or QRS, those are all electrical potentials. And electrical potential is going to be a vector. And so if we think back to what a vector is, it's going to be a force that has both magnitude and direction. And that's going to be quite important with, when it comes to identifying mean electrical axis. So factors that can affect the magnitude are going to be how strong the source is, which is typically going to be a reflection of the mass of the myocardium that the signal is going through. So that's why the QRS complex is almost always bigger than the P wave, because the ventricles have much higher myocardial mass than the atria. But another contributing factor to that is going to be the size of the chamber itself and the amount of blood within it, because it acts kind of to increase capacitance. So if you have eccentric dilation of a ventricle, that's going to be, going to give you a stronger signal, just the same way that concentric hypertrophy would. Okay. Another thing that can affect the strength of the signal is going to be how far the signal is from the surface electrodes. So again, if you've got really big animals and you're distally on the limbs, or you've got a really fat animal and there's a lot of tissue to get through, the complexes might be pretty small in appearance. And what's going to be very important with the magnitude is actually going to be the angle at which the depolarization occurs relative to the lead that we're looking at. And so when depolarization is parallel to a particular lead, then it's going to give us the largest deflection on our ECG. And we're going to see the weakest deflection when everything's perpendicular. So if we look at these examples here, this would be kind of pretty typical of normal depolarization through the heart. So typically it goes top to bottom, right to left. And lead 2 here again reads from right arm to left leg. So it reads in pretty much a parallel plane to normal depolarization. So that's why lead 2 often has one of the biggest QRSs when we look at a 6-lead ECG. Again, sometimes depolarization changes a little bit. Maybe it's directed a little bit more towards AVR here. And so in lead 2, again, we're still looking at lead 2 in all these examples. Because it's now less parallel, the QRS complex is smaller. And here in this third example, our depolarization is now completely perpendicular. So this might be, like a right-sided VPC or something like that, that's starting in the right ventricle and then spreading across in this direction. And here we're getting in lead 2, it's looking quite isoelectric. Then if our vector is starting in this direction, we're now going to be negative. And we'll talk about that in just a second, but essentially you're going to get positive deflections anytime your vector is headed towards the positive pole, and you're going to get negative deflections anytime it's headed away from a positive pole or towards a negative pole. Okay? And again, depending on how parallel you are with that lead will determine the magnitude of the vector. Here we have a same magnitude as what we have here, but it's now negative because it's headed towards the negative pole. So again, to kind of determine that, you'll have to kind of somewhat cast this to memory. I wouldn't worry about casting it to memory too much. You can always quickly Google an image like this, for Bailey's hexagonal lead system, that will show all 6 leads together and their positive poles. And so again, like I said, waveforms are going to be positive in any individual lead. So if we look at, doesn't matter if it's lead 1, lead 3, lead AVR, lead 2, in that particular lead, if the wave of depolarization is headed towards the positive pole in that lead, it will give you a positive depolarization. But if it's headed towards a negative pole of any particular lead, it'll give you a negative deflection. So here's just an example of that. So this is a dog who had a bit of a left bundle branch block. And so we've got our P waves here. We've got our QRS complexes. And we're not seeing T waves very well in this dog. They're kind of getting summated with the P waves. But if we look at electrical axis, there's 2 ways we can assess it. So one is the isoelectric method, where we look at the lead that has kind of the closest net to 0 in it. If we take what's above baseline to what's below baseline, whatever's left closest to 0 is going to be considered isoelectric. And so that, for example, in this case would be lead AVL. So we've got a little bit of negative deflection, we've got a little bit of positive deflection. They kind of cancel each other out. So what we would be left with is probably closest to a flat line compared to any of the other leads. So then we can go and look at this system and look and see, well, what lead is perpendicular to AVL? So we've said that AVL is isoelectric. The isoelectric lead is always perpendicular to the mean electrical axis. So then we look and see, well, which one is perpendicular? We find it's lead 2. So we know mean electrical axis must sit somewhere along lead 2. Now we need to ask ourselves, is it at the positive end of lead 2, down here at positive 60? Or is it at the negative end of lead 2 up here at negative 120? And to do that, we simply look at lead 2 itself and we ask ourselves, is it predominantly positive or negative? And in this case, it's predominantly positive, so it must be directed towards the positive pole of lead 2. So our vector is going to be headed in this way. Okay. Here's another example where again we've got a slight difference here now, and now when we try to look for our isoelectric lead, it's a little bit harder. So again, our isoelectric lead is probably quite close to being lead 2 in this case. We've got a positive and a negative component to cancel each other out pretty well. And so again, we'll look here and look at lead 2 and ask ourselves, well, what's perpendicular to lead 2? And we find it's AVL. So we're going to look at AVL here and say, well, AVL is negative. So my wave of depolarization must be headed in this direction towards the negative pole of AVL. Okay? Now, even though it's a positive 150 degrees, that's simply the degrees here. The poles are marked in red, and the positive pole of AVL sits at negative 30. So it's actually directed in this manner. Okay? And so another way you can kind of check yourselves without having to do the isoelectric method, there's an even quicker method of doing it. And you can simply look through all 6 leads and you can ask yourself, well, which one has the biggest magnitude deflection? It doesn't matter if it's a positive deflection or a negative deflection. Which one, when you subtract what's below baseline from what's above baseline, will give you the biggest deflection? And if we look at this example here, we look through our 6 leads. I think it's pretty fair to say that lead 2 would give us the biggest deflection. So again, we know straight away lead 2 is probably mean electrical axis, and then we ask ourselves, is it positive or negative? In this case, it's positive, which gives us that vector. Okay. We can do the same thing here. We can ask ourselves, which one is going to give us the biggest deflection when we subtract above from below baseline? And this example is going to be pretty close to lead 1 or to lead AVF. AVF doesn't have anything above baseline. It's all below baseline. Lead 1 has a little bit above baseline, but a little bit more below baseline than AVF has. And when they cancel each other out, they're probably pretty similar. So we find that the net vector is kind of headed in this direction. And in reality, it's probably somewhere between the two. Again, if we look at lead 1, it's predominantly negative. So that fits. We're headed towards the negative pole of lead 1. Same with AVL, negative pole of AVL. And you can look through each of the leads and see, where the depolarization is headed. So, just by having an idea, you can check yourself to see, well, yeah, this is right or this is wrong, when you suspect that there is a change in the mean electrical axis. The normal mean electrical axis in dogs is typically from about positive 30, potentially positive 40, all the way up to about positive 110 degrees. So this kind of quadrant here is what we expect the mean electrical axis to sit in a normal animal. Anything on this side of the patient up to negative 90 up here, it's going to be a right axis deviation of the mean electrical axis, or a rightward shift. And then anything to this side of it here up to negative 90 is going to be a leftward shift of the mean electrical axis. So that brings us on to the basic mechanisms of arrhythmias themselves. And broadly, we can break them down into three kind of overarching categories. So we can either have issues with impulse formation. So that can mean that either we're not getting impulses being formed with certain arrhythmias, or we're getting too many impulses formed, or abnormal impulses. So things like VPCs, ventricular premature complexes, or atrial premature complexes. The AV node can also have abnormal complexes. We might have impaired conduction. So we might have normal formation to begin with, in the SA node. We might get normal conduction through the atria, but then we might get conduction blocks either at the AV node or in the bundle branches going down. So those are typically going to be all the conduction blocks, and can be lumped under that. And then the third big category is going to be a combination of both, and those are quite complex arrhythmias. So we can break it down into other causes as well. And so, one of the big ones here are kind of highlighted in blue. And so automaticity, abnormal automaticity is a big factor with arrhythmogenesis. And so that's when cells are excitable and start to fire on their own and don't listen to the dominant pacemaker cells. So that's a lot of cases of VPCs and ventricular arrhythmias are examples of enhanced automaticity. Sometimes we'll have triggered activity, so we might have abnormal pathways within the myocardial tissue, which will allow stimulation of parts of the heart before they should. So we can have bypass tracks that bypass the AV node, and so SA node stimulation can be essentially shot straight down to the ventricles before the atria have finished contracting. So we can have issues like that. And then we can have re-entry, which again is associated with abnormal tracks. So it can be associated with those bypass tracks that we just talked about. It can also be a factor with things like atrial fibrillation, where you might get kind of a pathway of active cells that kind of, by the time one cell finishes depolarization and has completed its repolarization, its neighbor has now is now depolarizing, and by the time that one finishes, it's going to set off its neighbor again. And so we can see those patterns of re-entry as well in a lot of cases of arrhythmias. So, starting off on some individual arrhythmias, obviously, before we can address arrhythmias, we need to look and identify normal. And so looking at normal sinus rhythm, again, we're going to go back to, that kind of standardized approach. So, we're going to calculate the heart rate, and then we're going to look at our complexes, and we're going to look at the overall rhythm. We're going to ask ourselves, well, is this regular or is it irregular? And overall, it's pretty regular here. Same on this example down here. This is a dog, this is a cat. Okay, so we ask ourselves, can we identify P waves? We look through and we can. So we've got P waves here all the way through. They're all positive. These have a normal appearance of P waves in lead 2. And we ask ourselves, can we identify QRS complexes? And we pretty much can. So again, in lead 2, they should be nice, narrow, and upright in lead 2. Again, we can identify these all the way through. Can we identify T waves? We can. So these are these negative deflections down here. So again, like I was saying earlier, they can be positive or negative. In this dog here, they're negative. In this cat down here, they're positive. Then we need to ask ourselves, okay, well, we've seen P waves, we've seen QRS complexes, but are they associated? Is there a relationship with them? And we look all the way through and we look at that PR interval, and it's pretty identical on each complex. So we can say here with good confidence that yes, these P waves are associated with these QRS complexes. So there is what we call AV association. And so we know that then these must all be transmitted down from the sinus node through the conduction tissues to the Purkinje fibers. So this then would be our normal sinus rhythm. And again, that definition is going to depend on what the heart rate is overall as well. So typically less than kind of 170, less than 180 is going to be considered normal for dogs. Cats, they get a little bit excited, particularly in the clinic, so their sinus rate can get up to 200, 220 in some circumstances. Sometimes we can have a sinus arrhythmia. We see that quite frequently in dogs in particular, and that's attributable to having high vagal tone. They often have really high resting vagal tone, and that's going to change the speed at which the SA node is going to fire. So it works on those sodium and transient calcium channels that were causing a gradual upstroke in the action potential of the pacemaker cells, so that have a different looking action potential that we looked at earlier. And so we'll then get a variation in the R2R interval as the vagal tone changes. So the higher the vagal tone gets, we're going to get slower R2R intervals. So the R2R interval is going to get wider. And then as as vagal tone reduces and sympathetic tone increases, the R2R interval gets closer again. And that may or may not be associated with respiration. In some animals it is. In that case, we'll call it a respiratory sinus arrhythmia. But in some animals it's not, and they can just have it for other causes of high vagal tone. So other causes that we need to consider would be things like ocular disease, respiratory disease, severe GI disease, and severe metabolic derangements. Those are usually kind of the classic issues that can cause high resting vagal or high vagal tone without or in the presence of pathology. But sometimes it can be just a normal physiologic finding in dogs. It should disappear with heart failure. If you're seeing this in patients, that are presenting with respiratory distress, then the chances of it being heart failure are going to be pretty slim. It's much more likely going to be the result of primary respiratory issues in those cases. So that's another factor that can help you out in some of these ICU patients. Remember, when you've got heart failure, you've got pulmonary edema, the patient is essentially drowning in their own fluids, and like any of us, if you're drowning, you're going to get panicked and your heart rate's going to go up. So we shouldn't see sinus arrhythmia in the presence of active failure. Sinus tachycardia, we're going to see all the same hallmarks that we discussed, except now our heart rate has exceeded those values that we talked about. So greater than 180 in dogs, greater than 220 in cats, but we can still see all our classic findings. So we can still see our P wave, we can still see our QRS, we still see our T wave. Now, eventually, as the rate gets faster and faster, this interval here between the T wave and the next P wave is going to get shorter and shorter until eventually the P wave might be hidden in here. And once we get to that stage, then we're dealing with more supraventricular tachycardias and the like. So then looking at some ventricular ectopic beats, or premature beats are simply one type of ventricular ectopic beat. Ectopic just means that it's arising outside of the normal conduction pathways. And so, we're going to specifically talk about VPCs tonight, but this is also going to be pretty true for ventricular escape beats. The morphology is going to be pretty similar for a lot of them. So obviously they're going to arise from the ventricular myocardium below the AV node, and depending on how far below the AV node they arise, the morphology will look closer and closer to a normal QRS. So if VPC is starting near the bundle of His, it's going to look relatively similar to the normal QRSs that are there. It's still going to be a bit wider, it's going to be a bit bizarre, but as compared to a signal that arises from deep in the apex of the ventricle, that's going to look really wide and bizarre because it started really far away from the AV node. They're wide and bizarre, and the reason for that is that once the abnormal myocardiocite starts the VPC, then the wave of depolarization spreads from cell to cell, from neighbor to neighbor, to depolarize all the other cells. So that's going to take a much longer time, and so we're going to get widening of our QRS complexity here. And as the first cells have started to repolarize, some cells are still depolarizing. And so our T wave kind of slurs into the QRS, and it becomes this wide and bizarre and abnormal complex. They can occur on their own, so we might just have lone VPCs like we have here. We can have couplets where we'll have 2 together. We have triplets where we'll have 3 together. And the important thing that can help you distinguish if you're dealing with a ventricular ectopic beat, particularly a ventricular premature complex, as opposed to a supraventricular complex that could be causing a bundle branch block, is to look at the R2R interval surrounding the beat. So if you look at the normal sinus beat before, the normal sinus beat after, and you look at that R2R interval, it's going to be exactly twice the preceding R2R interval. So essentially, the next QRS occurs when we expect it to occur because the atrial rate has been unaffected. All of this has been happening in the ventricles, and the atria are insulated from what's happening in the ventricles because of the AV valves. They're very fibrous, and so it doesn't reset the SA node. So the SA node has simply carried along here like nothing was happening, and it actually fired somewhere in there, but it didn't result in a QRS because the ventricles were already depolarizing. So it just carried on and fired at the next appropriate time and then resulted in a normal QRS. So this is what we call a compensatory pause. It's compensated for how early this complex came, and it simply waited and came along when it should. Again, the morphology that we're going to see is going to be very variable depending on what ventricle the abnormal complex is arising from. So when we have VPCs arising from the right ventricle, then we're going to get a tall and positive appearance of the abnormal QRS in lead 2. So again, here are our normal sinus beats. We've got our P wave, PR interval, QRS, T wave, and then here we've got an abnormal QRS here. So we've got a VPC here. And we can see that it's predominantly positive and upright in lead 2. And this is very characteristic of what we see with VPC starting in the right ventricle. It's kind of very classic for dogs with arrhythmogenic right ventricular cardiomyopathy that we'll see these types of VPCs. So this is kind of the classic VPC that you would expect to see in a boxer with ARVC. This is also the type of morphology we would see if we had a left bundle branch block. And so with a bundle branch block, the left or right bundle branches might develop areas of fibrosis, which will then block conduction down through to whatever ventricle is being blocked. And so then the ventricle that's not being blocked will depolarize normally, and then from the septum, we'll get cell-to-cell depolarization across the remaining ventricle that's been blocked, which will prolong everything. So this is also sometimes known as left bundle branch block morphology when you see these types of VPCs. But again, if we were to determine if this was a bundle branch block or not, we would look and see, well, is there a P wave associated with it? And we look here and we don't have any clear association with P waves. There's a P wave in front of this complex here, but there isn't really anyone here. There's none in front of this one, nothing in front of this one. So we don't have AV association here, we have AV dissociation. So that's how we know that these are VPCs and not a bundle branch block. Okay. Similarly, if we've got the signal arising from the left ventricle, then it's going to look a little bit more like the classic VPC that we think of. So it's going to be predominantly negative in lead 2. And again, it's still going to be wide and bizarre because we're still going to have to depend on cell-to-cell-to-cell conduction. Okay. Sometimes it's known as a right bundle branch block morphology because right bundle branch blocks will also be negative and wide. So touching on drugs, again, we're going to go back to the action potential and look at the different phases of the action potential to decide what drugs are going to be effective or ineffective for certain arrhythmias. So particularly when we're looking at ventricular arrhythmias, we're going to be more interested in class 1 antiarrhythmics, which are going to be the sodium channel blockers. Specifically in our small animal patients, we're really going to be considering lidocaine, which is a 1B, or procainamide, which is a 1A. These other, flecainide, profafenone, we really never use them in veterinary medicine. Quinidine is typically used in horses. Phenytoin is again mainly used in humans and occasionally in horses. Again, we look at phase 2 and we look at our calcium channels, then we're going to be looking more at drugs like diltiazem, or in older days we use verapamil. When we want to deal with the potassium channels, then we're going to reach for things like amiodarone and sotalol. And then for the phase 4, for both supraventricular and ventricular cells, then the beta blockers are going to have some effects. So things like propranolol, metoprolol, atenolol, esmolol, those are all drugs that are going to work on the resting membrane potential. So they're hopefully going to delay the time to the next depolarization wants to occur. So the breakdown of the antiarrhythmic drugs, there's the traditional Vaughan-Williams classification. So class 1 are going to be our sodium channel blockers, which are broken down into 1A, 1B, 1C. Got class 2 are our beta blockers, class 3 are our potassium channel blockers, and some potassium channel blockers will have effects of other classes. And then we've got class 4, the calcium channel blockers. And we also have a miscellaneous category where we have digoxin and magnesium, which don't fit nicely into any of the classes, but will sometimes get used for antiarrhythmic purposes. Breaking them down a little bit closer looking at the sodium channel blockers, all the sodium channel blockers are membrane stabilizers. So they're really good, particularly for ventricular arrhythmias because of that quality. So the class 1As, procainamide and quinidine, they prolong repolarization, so they make the action potential duration longer. So the cell essentially is refractory for longer and less responsive to another VPC occurring. And so we can use it for ventricular tachycardia. It's also used for supraventricular tachycardia as well, because it will also have similar effects on the atrial myocardium. But the 1As can have side effects like nausea, vomiting, diarrhea, and hypotension. And we move on to the class 1Bs, and these are, the mainstay of treatment for ventricular arrhythmias, specifically lidocaine. And so these shorten the repolarization time, and they actually shorten the action potential duration. So they try to get the cell back to normal and back to a resting membrane potential before the next excitable stimulus can come along, so that it can then just revert to a normal rhythm again. Side effects that we can see with that are going to be CNS excitement, particularly seizures, tremors, things like that. Cats are really sensitive to it, so we have to be very careful dosing them with lidocaine. And GI upset is another typical sign that we'll see with these. And these, like I say, are going to be mainly used for ventricular arrhythmias. Again, class 1Cs, they don't really affect the repolarization time and don't affect the QRS duration. They have been used in research settings for both supra and ventricular arrhythmias, but they're not really used clinically for our patients. And again, we see very similar signs to the other sodium channel blockers. If we look at the class 2s, these are all the beta blockers. So again, atenolol, esmolol, propranolol are probably the most common ones we're going to reach for. And they're going to block the beta adrenal receptors, which is going to result in slowing of the AV node. And they do that by delaying the gradual upstroke of phase 4 in those pacemaker cells, so delaying the time until the threshold can be reached. So primarily, we're going to use those for supraventricular arrhythmias because they're going to work best on the SA node and the AV node. Side effects we might see, because they're blocking adrenal receptors, they're going to be negative inotropes. So if we have patients with severe cardiac disease, we want to try and avoid these drugs if possible, because we could decompensate them. So that's why it's always best, if you're not sure if you're dealing with a supraventricular arrhythmia or a ventricular arrhythmia, then you should probably reach for ventricular drugs first, just on the off chance that it is a ventricular arrhythmia, and you're not giving a negative inotrope that could reduce cardiac output even more. Then our class 3 drugs are potassium channel blockers, primarily sotalol and amiodarone. Sotalol does have some beta blocker activity at higher doses. So it can trick people out because it sounds a lot like the beta blockers, but its beta blocker activity is only at quite high doses. Primarily, we use these for ventricular arrhythmias. Occasionally, they can be used for supraventricular arrhythmias, particularly amiodarone. And amiodarone is quite good for atrial fibrillation. Side effects of sotalol, typically going to be bradycardia, hypotension. Occasionally we can see GI signs. And the problem with the bradycardia and hypotension is that some of those signs and lethargy are going to be very similar to what the patients are experiencing as a result of their arrhythmias. So sometimes it can be hard to tell is it a response of the drug, or is the drug not working effective enough and they're continuing to have severe arrhythmias. Amiodarone is quite an unusual drug in that it has a lot of weird side effects that are idiosyncratic. You're not going to be able to predict which animals are going to develop them. A lot of times they're rate responsive, but sometimes they're not. The classic complication that we see with amiodarone is the idiosyncratic hepatotoxicity that is rate responsive, and if you discontinue the drug, it goes away. So you need to keep an eye on liver values in animals you have on this drug. It can also impair thyroid function. It can both decrease thyroid function in some patients, and it can increase it in some patients. So that's a little bit of an unusual side effect that we get with that. like with most antiarrhythmics, it has the potential to cause hypotension. And I guess one of the biggest side effects that we're typically worried about with it is the possibility for idiopathic pulmonary fibrosis. Which has been reported in humans. It hasn't been properly documented in the veterinary literature, but there are some anecdotal cases out there amongst cardiologists that have witnessed this in both cats and dogs after administration of amiodarone. And the problem is that when it does develop, it is an irreversible change, and it can be left with very severe pulmonary issues afterwards. So that's why a lot of cardiologists will prefer to reach for sotalol before reaching for amiodarone if we're wanting to reach for a class 3 antiarrhythmic. Class 4 drugs are calcium channel blockers. Predominantly, we're going to use diltiazem. We rarely use verapamil nowadays. It's going to slow AV node conduction. So again, it's going to work on those pacemaker cells. And so we're going to use it for those supraventricular arrhythmias because it's slowing the rate at which signals can be passed through that AV node. So we're going to use it for atrial fibrillation and other supraventricular arrhythmias. Now, again, it does have some negative inotropic effects, not to the same degree that we get with beta blockers, but it's still a consideration. And so again, this is why if there's any concerns for could this be ventricular rather than being supraventricular, then err on the side of caution and start with a supraventricular drug. Then we move on to digoxin. It's cardiac glycoside, one of the oldest cardiac drugs that we have, was kind of grandfathered into use and would probably never get FDA approval nowadays because of its potential for side effects. But that also slows AV node conduction. So we use it for very similar indications as we would for diltiazem. So also using it for atrial fibrillation classically, but also some other types of supraventricular arrhythmias. The upside to digoxin is that it is a positive inotrope. It's not a very strong positive inotrope. Pimobendan's a far better positive inotrope, but it's certainly better than nothing. And if you have a patient who has very severe disease, you know, like DCM or something like that, that also has atrial fibrillation, then this could be potentially a good drug to add in because of those positive inotropic effects. Like I said, the downside is that it does have quite a narrow safety margin, and so common signs that we'll see will be gastrointestinal signs, and then as we get more and more toxicity, then we might start to see CNS signs, and then as we get more and more toxicity, it gets cardiotoxic, and it has interestingly been documented with every other type of arrhythmia with digoxin use. So. Then magnesium. So magnesium doesn't have a lot of published veterinary studies at the moment. It is a membrane stabilizer. It's used quite a bit in humans for treating ventricular arrhythmias, it is used a little bit in veterinary medicine, but like I say, we don't have any good studies to show if it's really good at preventing ventricular arrhythmias or not. So it's not used as a first-line drug, but certainly used as an adjunctive drug in refractory cases. Potential side effects of magnesium are going to be hypertension, vomiting, potentially paralysis, and depression. So now we're going to move on through some examples of various arrhythmias that we might encounter, and some are going to be malignant, some are not going to be malignant. So this is probably the time to get typing there, and we're going to see this is a 6 leads. So we got lead 1, lead 2, lead 3, AVR, AVL, AVF, and this is a continuous lead 2 at the bottom. So who wants to venture out and maybe consider what we're looking at? Who wants to be brave and try to make a diagnosis? So we don't have a particularly fast heart rate. Again, we're going to go back to that systematic approach. We look at the rhythm overall, pretty regular. We're going to ask ourselves, do we have a P wave for every QRS? We look to P wave for every QRS here. Do we have QRS complexes? Yep. QRS for every P wave? Yep. Are they associated? Yeah. Okay, all these PR intervals are fixed. Okay, so we must be dealing with some type of sinus rhythm, right? But we've got these weird looking QRS complexes. So what might we have that's going on? Anybody going to be brave in the chat and posit a guess? Oh dear, it's crickets out there. Okay, so we've got a wide and bizarre QRS to a certain extent. Yeah, so we're seeing bundle branch block come up. Good. Okay, so we're dealing with a bundle branch block. Now we need to ask ourselves, is it going to be a left bundle branch block or is it a right bundle branch block? Okay, so we're going to look at the mean electrical axis. And so we look on lead 2. Lead 2 is predominantly negative. So that's going to be more consistent with a right bundle branch block morphology. Okay. So essentially the right bundle is blocked, so the right ventricle isn't depolarizing quick enough. Left ventricle is starting to depolarize normally, and then we're slowly getting cell to cell to cell depolarization of the right ventricle starting at the interventricular septum. Okay. So that's going to give us a predominantly negative QRS and a rightward shift of the mean electrical axis. Now I see that there was some comments, maybe it's a VPC. And again, if we were just looking at the complexes themselves and not considering the P waves, that would definitely be valid for a left-sided VPC. But because we already answered that we've got a P wave for every QRS that's present, that tells us that it can't be a VPC because the P waves are associated with the QRSs. And we don't have that when we have a VPC. With VPCs, we have disassociation of the P waves and QRS complexes. Okay, so this is an example of right bundle branch block. Again, because the overall rhythm is sinus, then when you listen to this patient, you're not going to hear an abnormality. They're going to sound completely normal. So this is really something that you're only going to see on ECG. You're not going to identify it on physical exam. When we look at a left bundle branch block, this time again, we do have a somewhat wider QRS complex than what we expect. These are our normal QRS complexes here. Okay, we can see these QRS complexes are now wider and taller. Okay, but they're still positive in lead 2. So they're still headed towards the positive pole of lead 2 when we think of that hexagonal lead system, which means they're still directed towards the left ventricle. So that means that the left bundle branch must be blocked. So the signal is starting in the right ventricle and then moving right to left so that the vector is headed towards the positive pole of lead 2. So that's why it gives you a tall and slightly wider QRS complex. So this is what a left bundle branch block would look like. Again, how we know it's a bundle branch block and not a right-sided VPC, which would have the same direction, is that we have a P wave that's associated with every QRS that's present, and the PR interval is fixed. So again, we have association present, so this must be a bundle branch block. So again, just touching on bundle branch blocks, they're not going to disrupt the rhythm. You're not going to hear any abnormality when you listen to these animals. They occur because we've got delay or block of conduction within one of the bundle branches. If both bundle branches are blocked, then you're going to have complete AV block, which is going to look a bit different. And right bundle branch block is going to be way more common. It's way more susceptible to injury than the left. You'll most commonly see it with dogs that have pulmonic stenosis, particularly after they undergo balloon valvuloplasty. Because it's very superficial in the right ventricle, it often gets damaged during ballooning, and so it'll become quite prominent. It's often, we kind of consider it a marker that we've actually done something when we've done a balloon valvuloplasty, that we must have been in the right place if we end up with a right bundle branch block. And so really the only thing that is different with a bundle branch block from sinus rhythm is that the QRS duration is prolonged, with the cutoff being 80 milliseconds in dogs. Okay, but the rhythm is still going to be just a normal sinus rhythm. There's going to be a P wave for every QRS, QRS for every T wave, or P wave, I should say. Okay, then when we're dealing with right bundle branch block, the mean electrical axis is going to be shifted to the right. Okay, so we're going to have a negative QRS in lead 2. And a left bundle branch block, the mean electrical axis is normal. It's still going to be upright in lead 2, but it's still going to be wide. Okay. All right. So now we've got some more examples. So who wants to take a stab at this one? So we've got leads 1 and 2 here. This is going to be a normal sinus beat here. And we've got all this time until we get this beat. And we have another 2 normal beats here, and then we've got more time before we get this beat. So anybody want to take a guess in the chat? Yeah, so I see 6 sinus syndrome come up. Good, okay, so this is sinus arrest, which can be one of the changes we might see with 6 sinus syndrome. I guess specifically, it's more reflective of sinus node dysfunction. 6 sinus syndrome itself is the term we apply once we have clinical signs as a result. So if this dog was collapsing, yeah, we would definitely call it 6 sinus syndrome. But here we've got normal sinus beats followed by no P wave at all. Okay, so our sinus node is simply shut down. P waves are not responding, but then occasionally they'll sporadically have a P wave. So this is all an issue with the sinus node. It's simply firing and then forgetting to fire. And then the ventricles get a little bit tired of waiting, they get a bit impatient, and they're going to fire on their own. Again, like I said, depending on how close to the AV node the ventricular signal starts, the closer to normal it's going to look. So usually we're going to get the pause is going to be interrupted by an escape beat. So this is an escape beat here. Okay, it can still be considered a ventricular ectopic beat, but it's an escape because it doesn't come prematurely. It comes after a delay. Okay, we look at this escape beat here, and it's almost identical to the sinus QRS beats. So this one would be more what we would call a junctional escape beat. So this would be a ventricular escape. This could be a junctional escape. And the ventricular escape could have very different morphologies depending on how far down the ventricle it was arising. All right. So another example here. So again, lead 1, lead 2. So again, you're kind of getting the routine at this stage. You're going to look at the overall rate. Doesn't look too bad. Something happened here in the middle. Okay, we're going to identify our P waves. Yep, looks like we have P waves. We're going to identify QRS complexes. Yep, can identify QRS complexes there. Do we have QRS for every P wave and P wave for every QRS? I think we can answer yes to that. Okay. So what do we think is going on here? Anybody want to give a guess in the chat? Okay, so sinus arrhythmia came up as a thought. Not an unreasonable thought. I think the problem here is that this is just too abrupt a change to be sinus arrhythmia. So sinus arrhythmia should be a very gradual change. It shouldn't be all of a sudden change and then go back to the normal rhythm. So we have a very abrupt change here with a QRS complex that looks identical to the sinus ones. So this is an example of an atrial premature complex. And so how do we know this is atrial premature versus ventricular premature? Primarily, we're going to look at the QRS itself. Okay, and we see this QRS on the premature beat. It's identical to all the QRSs that had a P wave. So we know that ventricular activation has to be the same. It has to be starting at the AV node and going down through the bundle branches as normal. So that means that the abnormal signal must be starting above the AV node. So we must be dealing with either with an atrial premature complex or a supraventricular premature complex. Now the problem here is that we can't really see the P wave clearly, and it's hidden within the T wave of the preceding complex. So if we look at the T waves of the other complexes here, we can see that they're not particularly tall. They're about as tall as the P waves. But then we see this P wave here, and it's just a little bit taller than the P wave is. So that tells us that there's some summation of signal going on here, and there's actually P wave hidden in here. So this is an example of an APC. And again, the other thing that tells you it's an APC and not a VPC is the non-compensatory pause. So if we look here, this R to R interval is the same as the other R to R intervals. Okay. So you've got this sudden change, and then the SA node has been reset so that it fires when it thinks the next beat should start. So it starts, you know, at whatever rate this is, you know, about 130 beats per minute, starts that number of milliseconds after that preceding beat. Whereas if this was a VPC, then this would be a much longer pause. And the gap here would be more than twice this R to R interval. So when we get runs of those together, we're going to end up with an atrial tachycardia or a supraventricular tachycardia. And so again, we've got some sinus beats that help us out a little bit because we know, okay, there's a P wave, there's a QRS, so they're all associated. So we know that this is what a normal QRS looks like. And then we look at all these rapid beats and they look pretty close. They look to be at least 90% of what the normal beats look like. Okay? But they're far too rapid. Okay, these are super, super fast here. So we've got this sporadic run of atrial tachycardia. Again, atrial tachycardia is going to be very regular. The R to R interval during the tachycardia, these R to R intervals are all going to be identical. And then as we look throughout the strip here, we've got some APCs jumping in and some little short runs of atrial tachycardia here. Okay, and then back to sinus rhythm. Oftentimes there'll be one APC that starts a run and then the whole run will take off from there until it finishes. Now, compared to ventricular tachycardia, atrial tachycardia is usually fairly hemodynamically stable. A lot of patients will have atrial tachycardia, but they'll still be walking around, so they're not quite as emergent as ventricular tachycardias can be. But in some dogs, if they get particularly rapid, they can definitely cause clinical signs like weakness, collapse, and hemodynamic compromise, and might need to be treated acutely. So acute treatments that we can consider, oftentimes the first kind of acute treatment. So again, when we're talking about acute treatment, I'm talking about kind of the ER setting, the collapsed dog that comes in, you hear this rapid heart rate, take an ECG, and you have findings similar to what we've seen here, and they're collapsed, obtunded, and their blood pressure is poor, and those are dogs that we really need to address with acute management. So we'll reach for IV medications in those animals, and so probably one of the best IV medications for treating supraventricular arrhythmias would be diltiazem. And our dose is going to be much lower than the oral dose of diltiazem. And this is a big thing to keep an eye out for, because I have seen plenty of dogs that have been overdosed with the oral dose given IV essentially, and that makes them super weak. They're essentially near comatose until the diltiazem wears off. So it's something to be very conscious that the IV dose is way, way lower than the oral dose. And we can continue it as a CRI if it works well and breaks the arrhythmia. But if it doesn't, then we have to think of some other options. And I see in the chat here, some people have already thrown out some other options. And so our second option would be beta blockers. And typically in this acute setting, then esmolol would be a beta blocker of choice. And one of the reasons that we really like it for acute settings is because it doesn't last as long. It's very short acting, and the maximum effect is usually reached within 4 to 5 minutes of administration. And it has a half-life of only about 9 minutes. So if it happens to severely depress myocardial function because of those negative inotropic effects, then it's not going to be on board very long. So you can give it, see if a beta blocker is going to help this arrhythmia, and if it's not going to help it, well, then it's out of the system within kind of 20 minutes or so, and you don't need to worry about it anymore. So that's why it's often, of the beta blockers, it's a good one to consider rather than jumping to oral medications first. Okay, we can try vagal maneuvers, so we can do the oculocephalic reflex, so where we press on the eyeballs pretty hard, or you can also do deep carotid massage, so you really want to get in to try and stimulate the carotid bodies in the carotid artery just up near the angle of the mandible. Unfortunately, in cats and dogs, I've tried that many times, and they seem to be much more resistant to vagal maneuvers than humans are, and so it's always worth a shot because it's cheap and it's easy to do, and you can even do it first thing before you start drawing up drugs, or as you have a technician, or as you yourself are drawing up drugs, you can have somebody do a vagal maneuver to see if it'll break the rhythm. Sometimes it will, but it's in very rare cases that that'll happen. We can also consider procainamide. Now, procainamide is a sodium channel blocker, which we usually consider for ventricular arrhythmias, but it does work well on the atrial myocardium as well, and so it can be used for supraventricular tachycardias, as can sotalol and amiodarone. So we mentioned sotalol, at high doses at least, does have beta blocker effects, so it'll certainly have similar effects to what we're seeing up here, which will help a supraventricular arrhythmia, but it'll also help the potassium channels in the atrial myocardium as well. And amiodarone similarly will affect the potassium channels in the atrial myocardium, and it's often quite a good drug for atrial arrhythmias, with the limitation of the potential side effects that we might encounter with it. Now, we got that patient stabilized with that approach. Let's say the diltiazem worked and broke it initially. Then we need to consider some chronic treatments that we could use at home. And if we know that IV diltiazem worked, then we'd probably reach for oral diltiazem to prevent that arrhythmia from coming back. Now again, it's important to note that diltiazem comes in two forms. There's a standard formulation, which we need to give 3 times a day. It's going to be at a much lower dose. And then there's a slow release formulation, which we can give twice a day at a higher dose. So again, you need to just be conscious of what formulation you're using, so that you're dosing it appropriately for your patient. So that's usually my kind of go-to of choice for these patients with atrial or supraventricular tachycardias. We can use atenolol, which is kind of the oral beta blocker of choice for these patients. And again, we can give that every 12 to 24 hours. We can kind of titrate it to effect. And we can also use digoxin for some of these cases. Again, it's got a narrow safety range, so I'd usually try diltiazem first, but it's certainly worthwhile including it there. Okay, moving on to our next one. So again, we've got to go back and ask ourselves, those same questions again. Do we have P waves? Do we have QRS complexes? And so I think, yeah, we can identify P waves, but now we have to, and we can identify QRS complexes. But now we ask ourselves, well, do we have a P wave for every QRS? And we do. Every QRS that's there has at least one P wave in front of it. But then we ask ourselves, do we have a QRS for every P wave that's there? And we don't. Okay. So this would be atrial flutter. Okay. We still have organized atrial activity, but it's really fast and really rapid, and the ventricles aren't able to keep up. So we'll have this, what we consider a sawtooth baseline. Okay. So it's still organized, but it's very rapid. But the R-to-R interval is usually regular. So it's usually a fixed multiple of the number of P waves that are there. So again, usually you'll have like 3 P waves to every QRS or 4 P waves to every QRS. If it progresses, then it's going to get much more irregular. Okay? It's going to deteriorate into atrial fibrillation. And so we're going to lose that organized activity to the atria. We're not going to have any clear P waves. Okay, so we look through here and you could argue, oh, maybe there's one there, but then there's nothing here, there's nothing here, nothing all the way through. Okay? Our QRS complexes are still narrow and upright. They're still supraventricular in appearance. So they're still leaving the AV node as normal and stimulating the ventricles in a normal pattern. It's simply the number of signals that are hitting the AV node or bombarding it. So that's why we're getting such an irregular pattern here. So this is irregularly irregular or very chaotic. And so these are classic hallmarks of atrial fibrillation. It's going to have a narrow upright QRS. So it's going to be very similar to supraventricular QRS. We're going to have no clear discernible P waves. It's going to be fast. It's going to be irregularly irregular. Okay. When you listen to these guys on physical exam, they're going to sound like, some tennis shoes bouncing around in the dryer. Treatment for atrial fibrillation. Again, we don't need to worry about treating these guys acutely in most cases. A lot of times we'll see dogs with like dilated cardiomyopathy with atrial fibrillation, and oftentimes they're in heart failure. Always stabilize their heart failure first. Atrial fibrillation is very responsive to sympathetic tone, and the higher your sympathetic tone, the faster your atrial fibrillation rate will be. And so if you can reduce sympathetic tone, you'll often improve the atrial fibrillation rate quite drastically. So if you've got heart failure present, treat that first. So give the dogs oxygen, give them diuretics, give them pimobendan, and you can wait, several hours, even a day or so, to make sure they're nice and stable before you need to worry about treating the atrial fibrillation itself. Long term, we've got two options. We can either control the rate or we can control the rhythm. Ultimately, there's no difference in long-term outcomes regardless of which approach you take. Because most dogs have structural heart disease with atrial fibrillation, then usually we're just going to do rate control. Because rhythm control, we can convert them back either medically with amiodarone or we can use DC electrocardioversion. But because they've got structural disease, the likelihood is that they're just going to go back into atrial fibrillation again. So it's an expensive and risky endeavor to do, when you could just achieve the same long-term outcomes by giving them drugs. So again, you're going to use diltiazem at the same dose. You can use digoxin, is quite good for this. And a combination of the two is also quite good, and you can reduce your dose of each drug. That kind of have a little bit of a synergistic effect. You can also consider beta blockers for atrial fibrillation, although usually we'd leave those as a last-ditch effort. Okay, so now we've got another different appearing ECG here. So we've got P waves here. Got these QRS complexes are a little bit notched, so we might have some conduction disturbance in our QRS. And then we've got these big wide and bizarre complexes. Okay. And when we look at the pattern overall, we can see we've got sinus beat, abnormal QRS, sinus beat, abnormal QRS, and that pattern repeats itself. So this is ventricular bigeminy. And so we can have bigeminy or we can have trigeminy, and that's simply an alternating rhythm between sinus beats and ventricular ectopic beats. Usually they're premature. And again, if it's a one-to-one from sinus to ectopic, then we're going to call it bigeminy. And if it's 2-to-1, we're going to call it trigeminy. So we'll have 2 normal beats for every abnormal beat will be trigeminy. Again, oftentimes this is quite a stable rhythm because it's not particularly fast, and so you don't usually have to treat it acutely. But it may often indicate that you've got underlying disease present, which may be cardiac, may be extracardiac, but you need to investigate a bit further. Now, as things get a little bit worse, and we get our VPCs occurring more frequently, then we're going to start to have ventricular tachycardia. Okay. So in this example, here are sinus beats. We've got P wave, QRS all the way through, and then we suddenly get this very wide and bizarre QRS complex. Looks nothing at all like the normal QRS. And it's occurring earlier and faster than our normal R2R interval. So this is ventricular tachycardia, and same up here. Okay, it breaks briefly for our sinus beats, again, P wave, QRS, and then goes right back into ventricular tachycardia. And how we know it's ventricular tachycardia and not a supraventricular tachycardia with a bundle branch block is that we don't have associated P waves. I don't see, there was no P wave that initiated this first beat here. Okay, we've got PQRST, no P wave in here before this run started. Same here, no P wave started this run. So we don't have any association with the P waves, so we must be dealing with ventricular beats. So this is ventricular tachycardia. Again, we'll apply the term tachycardia when we have 3 or more VPCs in a row. It's going to be rapid and regular. So this is what differentiates it from atrial fibrillation, is that ventricular tachycardia is going to be really, really regular. And it's going to have a White-Bazar complex, which is either going to be positive or negative depending on which ventricle it's coming from. So in these examples, these are negative QRS complexes. So these are going to be very characteristic of dogs with DCM, like a Doberman Pinscher or something like that. If it was a boxer with ARVC, then we would expect these complexes to be positive in lead 2. So they would still be White-Bazar, but they would simply have a different polarity. So acute treatments of ventricular tachycardia, again, it depends a certain degree on how stable the dog is. So, you'll see some dogs, some boxers with ventricular tachycardia of about 240 beats per minute, and they're just running around, wagging their tail, panting away, just smiling at you, and they're doing just fine. They're very hemodynamically stable. And those are dogs that we can probably skip acute treatment and just move to chronic treatment, which we'll talk about in just a second. But you'll get other dogs who will have a much faster ventricular tachycardia rate, and it'll be very hemodynamically significant. They'll be obtunded, they'll have terrible blood pressure, their pulses will feel very poor. Those are dogs you need to address very quickly. Our first line of defense is typically lidocaine. Typically for a dog, we'll use a 2 mg per kg IV bolus, and we'll increase that up to a total of 8 mg per kg. Typically, I wouldn't use lidocaine as a first line dose in cats. I'd usually leave it for like second or third line, simply because of the higher risk of neurologic side effects in cats. And when I do it in cats, I would use only a much lower dose, so like a 0.5 to 1 mg per kg, and just titrate it slow IV to effect. If lidocaine's not working, then we could reach for procainamide. So typically I will use a 5 mg per kg IV bolus, and we can repeat that up to a total of 20 mg per kg. And oftentimes, in the vast majority of cases, lidocaine is going to be sufficient to break the rhythm. Okay, usually after maybe 2, maybe 3 doses. Okay? It's only rare you'll have to reach for procainamide, and again, not all clinics are going to have it available, but it also does a pretty good job. And some cardiologists like to use procainamide as a first line. And in cats, I would certainly use procainamide before I would use lidocaine as more of a first line drug. Again, in those, stable boxers that we talked about, or, if the dog is stable enough to at least protect their airways, and these first 2 drugs haven't worked, then, I'll often reach for sotalol and give it, we can only give it orally. We don't have an IV form of it, and at least give it, and we should start to see some effects within about, 20 to 30 minutes. It'll take 2 hours to kind of reach peak effect, but it can at least be on board and starting to work while we consider other options. And if the dog's not able to protect their airways and they're very obtunded, you might be able to administer the sotalol through an orogastric tube. Again, if none of those are working, then we'll reach for magnesium sulfate. Again, we don't have a lot of evidence in dogs as to whether it's definitively beneficial or not, but we would usually give it as a slow bolus over 10 to 15 minutes. And I've seen a few cases where that has helped quite a bit. So it's always worthwhile in these patients, when you've identified an arrhythmia, to get a minimum database, including electrolytes and including magnesium, to see if there's any issues there. And even if they're not hypomagnesemic, then adding magnesium can still help with stabilizing ventricular tachycardias. Then my next line of defense, we're kind of working our way down, and as things are not working, moving to the next stage would be amiodarone. It is quite a nice drug for ventricular arrhythmias, but like we said, it does have some weird side effects. So that's why we don't use it really as a first line. Again, we typically give it slowly over 10 to 15 minutes, and we can maintain them on a CRI if we find it works well. Now, it's important with amiodarone to be aware that there are two separate forms. There's a preservative-free form, which is called Nexterone. It's an aqueous-based solution, and that's the form that I would recommend using. The other forms contain carriers that are anaphylactic to dogs, so they might work well for the arrhythmia, but then you might have to deal with severe hypotension and anaphylaxis. So where possible, I would recommend using Nexterone if you are reaching for IV amiodarone. Again, if that's not working, then we're starting to run out of options. So one option is if you have a defibrillator available to you, then you can do electrocardioversion. Typically, we do that for dogs that are fibrillating, but you can do that in patients that have pulseless VTAC. So if there's no pulses there, the dog's obtunded, they're not responding to any drugs, then it's certainly warranted to go ahead and try and do electrocardioversion. It's essentially shock them. And if you don't have a defibrillator available to you, you can essentially achieve the same effect by doing a chest thump. So you can, again, you're going to apply a pretty firm force with your hand, kind of an axe handle blow to the precordial chest. So where you would feel the apex beat the best, that's where you're going to want to aim for, and then give a fairly forceful thump to that side. Essentially, all you're doing is the same thing that's happening with cardioversion. With cardioversion, we're supplying energy by means of an electrical shock. With chest thump, you're applying electrical energy you're applying energy by means of a physical shock, and that's going to stimulate all the cells to depolarize at once, and then you're going to hope that the sinus rhythm is going to come back as normal. So that's how both of those methods are going to work. Chronically, obviously, we're going to look for any underlying diseases. Like I said, with ventricular tachycardias, we might see them with non-cardiac diseases as well as cardiac diseases. So if there's electrolyte disturbances, sepsis, things like that, you want to manage all of those in those patients. Sotalol is a great drug chronically. Again, we're often going to use that twice a day. We can use mexilotine, which is essentially the oral form of lidocaine. The downside to that is that you have to give it 3 times a day, and a lot of dogs are quite sensitive to it and get gastrointestinal signs. So usually we use sotalol as our mainstay of chronic therapy, but you can use both drugs together synergistically, and they will reduce the side effects and have even better control of arrhythmias. That's been shown to be the case, at least in boxers with ARVC. And then we can use amiodarone orally for chronic use, but we do run into those potential side effects that we talked about earlier. So things like hepatotoxicity, pulmonary fibrosis, thyroid dysfunction. So you have to closely monitor these patients. And there is a loading dose that we can use for 7 to 10 days. Obviously, if you started on IV, then you don't have to worry about the loading dose. And then there's a maintenance dose that we can do once a day. Some people do it every other day. Some people have variations on that where they might do 6 out of every 7 days and give one day break a week to try and minimize the risks of side effects. As ventricular tachycardia deteriorates, it's going to get worse and worse, and we're going to run into ventricular flutter. So it's now starting to have more of a sine wave pattern. Okay, it's getting harder and harder to identify individual complexes, but there is still some organization present. So again, we're still going to be running down the gamut of all those drugs that we just talked about for ventricular tachycardia. Okay, and as it continues to deteriorate, we're going to end up with this. So we're going to end up with ventricular fibrillation, where now we've kind of lost all the pattern. It's very disorganized. Okay, the complexes are all different sizes. It's just all over the show. And this is where we have to reach for, obviously start CPR and have to reach for the defibrillator. And if we don't have a defibrillator, we have to go and do a chest thump. Now, one arrhythmia that you're quite likely going to see in an ER setting is going to be accelerated idioventricular rhythm. Okay? And so accelerated idioventricular rhythm, or AIVR, we're going to look at lead 2 here for our example. Okay, all of these are ventricular complexes. They're wide and bizarre, predominantly negative with a large T wave. Okay? But the rate isn't particularly fast. The rate is actually within normal limits. Again, we don't have any obvious P waves here, so we don't have any evidence of association between P waves and QRS complexes. So these are ventricular, but they're not fast. Okay. So it's sometimes called slow VTAC, but it's at a normal physiologic rate. So it's usually going to be 120 to 160 in most cases. We see it very commonly with splenic diseases, often post-GDV correction. We can see it with acidosis, we can see it with trauma. So oftentimes it is present with non-cardiac diseases. There's really no reason to treat this. This is a hemodynamically stable rhythm. Okay. Simply the pacemaker cells of the Purkinje fibers are beating faster or firing faster than the AV node. And in the heart, whichever cell beats faster is going to get control. And so they just happen to be firing a little bit faster, but at a rate that is hemodynamically stable, so blood pressure is going to be just fine. And also a lot of treatments are not going to work. So lidocaine is a rate-dependent drug. It only works well at really fast heart rates. So at normal physiologic rates, lidocaine is not going to do anything for these complexes. And I've seen dogs, on lidocaine CRIs, for days on end, not changing these rhythms. Okay, so it's not necessary and usually not going to work. So kind of coming around full circle to where we started, we now have an example here of atrial standstill. So now we have QRS complexes, okay, and we've got our T waves, but we have no clear P waves. But we still seem to have these QRS complexes at a nice regular rate, almost like the sinus node is still firing. Remember, the sinus node we're not going to see on ECG, so it is still firing in these examples. Okay. So can anybody think of causes for atrial standstill in the chat? Yeah, so hyperkalemia. So that's going to be kind of the classic presentation that you're going to see with atrial standstill in the ER setting. And so this is the very same case as here. So this, when the dog presented, he actually had Addison's, and he was hyperkalemic at, I believe he was 7.8 at the time. And once we started to correct his hyperkalemia, we saw P waves came back. Our QRS complexes look the same, but now our P waves are back. Okay? So you can get a really rapid response in these patients, and also the overall heart rate has increased because the sinus node gets slower and slower the higher the hyperkalemia gets. So once you correct it, the rate is going to get a bit quicker as well. Okay, so again, we don't have P waves. Hyperkalemia is going to be the most common cause, so we're going to see it with those block cats, those DKA cats or dogs, and in Addisonian dogs. Okay. Again, as it gets worse and worse, the QRS complex is going to start to look abnormal as well. And we can see atrial standstill for other causes. So in English Springer Spaniels, we can see a direct cardiomyopathy of the atrial tissue, which is sometimes known as parchment atrium, where there's just no myocardial cells there and there's nothing to contract, so they won't have P waves. And so those ones are not going to be hyperkalemic, and they're not going to respond to therapy for it. So those are cases that you need to do pacemaker on. So here's just another example of a dog with hyperkalemia presented with 9.1 potassium. Again, we can see no P waves, and we've got these really abnormal looking QRS complexes. As the hyperkalemia was corrected, we get down to 7. QRS complexes start to look normal, but we still have absent P waves. And then once we get down close to normal, our P waves have returned, and we've got our normal sinus complexes. Okay, we've got our last couple of examples here before we finish up. So now we're going to look mainly at conduction disturbances. And I see we have a hand raised. Go ahead. Are we able to unmute that? No. Okay. So here we have we've got P waves throughout. We've got QRS complexes associated with every P wave. And we have, but if we look at the PR interval, our PR interval is prolonged or delayed. So this is an example of first degree AV block. So if the PR interval prolongs more than 100 milliseconds, we'll call it first degree AV block. It's not clinically significant. You're not going to find it on physical exam. You're not going to hear this abnormality because you're still having regular QRS complexes. You're having regular heartbeats. You're only going to see this on ECG. It's essentially just an ECG finding and doesn't require specific treatment. Okay, we move on a bit further, and we're now going to have second degree AV block. So now we're going to have P waves without associated QRS complexes. Okay, so we're going to have P wave just sitting on its own, and another P wave that does get conducted. So we have to have evidence of at least some of the P waves being conducted to call it second degree AV block. Now we've got two types. We've got Mobitz type 1 and Mobitz type 2. Mobitz type 1, also known as the Wenckebach block, is where the PR interval gradually gets longer and longer and longer until it gets delayed. So here we can see PR interval starts this long, gets a tiny bit longer here, gets obviously longer here, gets longer again, and then eventually the beat is just dropped altogether. So this is a very classic Wenckebach block. Usually indicates increased vagal tone. So oftentimes these are dogs where you simply need to do an atropine response and look for causes of underlying increased vagal tone if they do have a positive response to atropine. And usually these animals are not going to be clinical when they've just got type 1. It's usually going to be a fairly infrequent block. Mobitz type 2, on the other hand, we still have unconducted P waves. Okay, some are conducted. Here are conducted ones. Okay, but the PR interval is going to be identical for each of them. So that's what makes this a Mobitz type 2 second degree AV block. Now we can have low grade or high grade AV blocks, second degree AV blocks, and that simply reflects the number of P waves that are not conducted for every QRS. So again, the more P waves you have to QRS complexes, that's going to be a more high-grade block. And those are ones that are going to be oftentimes more clinical and are going to require treatment, usually by way of a pacemaker. I would always do an atropine response test in these dogs, just in case it is vagally mediated, and obviously address any underlying vagal issues. And then we move on to third degree AV block. So again, we don't have any association between P waves and QRS complexes. So we have lots of P waves here, we have some QRS complexes, but if we look before the QRS complexes, the P waves happen at all different rates. So this one happens just before the QRS, this one happens out away from it, this one is right on top of it. So there's no pattern to it, there's no association, they're disassociated from one another. Essentially, you've got two independent rhythms crossing across each other. You've got the rhythm of the atria that's fixed and just marching its way through. There's one P wave hidden right there. Okay, just marching its way through. And then you've got the rhythm of the ventricles doing their own thing. You've got a constant ventricular escape rate, which is going to be very characteristic of third degree AV block. It's also going to be known as complete heart block, and obviously they're most often going to be bradycardic, particularly when they've got a ventricular escape. The usual escape is going to be 20 to 40 beats per minute. Sometimes the escapes will arise from the AV node or the AV junction, and the rate's going to be a bit faster there. The rate's going to be kind of 50 to 70 beats per minute, and those dogs will be a lot more stable. When we do see this, these dogs do have an increased risk for sudden death, which is why pacemaker is recommended to be done emergently in these patients. Again, anytime you have AV block, regardless of whether it's second or third degree block, I would still do an atropine response test to see if there is severe vagal influence. But in a lot of cases, these third degree blocks are not going to respond to atropine and are going to require a pacemaker. Another thing you might see in an ER setting is a patient who's already had a pacemaker, and maybe the owners are in tune with things and are, bring them in because they're worried because the pacemaker is not functioning properly. And so with paced ventricular rhythms, again, we're not going to see association between the P waves and the QRS complexes. Okay? So the P waves are happening at all different intervals. So we've got two independent rhythms marching along one another. How we know this is a paced ventricular rhythm is because we have a spike. Okay, this is a pacemaker spike, and you get a sharp spike of activity, which is then followed by the QRS, and then this is a T wave in this example. Now the QRS morphology will be different depending on whether it's an epicardial or endocardial pacemaker, but they'll all have spikes. And the spikes can have different appearances as well. So they can be small, like in this example here, if they've got a bipolar pacemaker setup, which is the majority of setups nowadays. Or they can be really tall, like in this example, with a unipolar spike. And so this is sometimes something you'll see with epicardial pacemakers. And this is our very last example of this evening. I know I've slightly run over time a little bit. And so here, does anybody want to hazard a guess of what we're looking at here? I'll tell you that the rhythm is okay. We have P waves for every QRS. We've got QRS for every P wave. Our rate isn't too bad. It's mildly tachycardic. So premature complex, perhaps. I think we're kind of dealing with a sinus rate. More important to look. Oh, did somebody say PC? Yeah, exactly. Good. Okay. So we've got varying R wave heights, which is going to tell us that we've got electrical alternans, and the hallmark of pericardial effusion is the presence of electrical alternans. So when you see this on an ECG, again, patients are usually going to be tachycardic because they don't have good cardiac output, they're getting stressed, and you're going to see this. Now, it's important to note that this is not particularly sensitive, it's very specific. So when you see it, it's almost always effusion, but not all effusions will display this on their ECG. So you'll only see it with pericardial effusions about 60% of the time. The other 40% of the time, you're not going to see it at all. So again, it's just another thing to have on your radar with these patients that present with hemodynamic compromise if you see this change on the ECG. And with that, I'm happy to take any questions. I'm going to stop sharing. And if anybody has any questions in the chat or any if they're able to unmute themselves, then we can certainly do that.
Thank you so much, Dr. Aherne. Guys, if you have any questions right now, feel free to raise your hand. I can put you on, unmute you so that you can ask your questions. We may have about 5 minutes or so for Dr. Aherne to ask questions. I know he's relatively tired for the evening. Guys, if you have questions, feel free to raise your hand. I can unmute you and we can try to get your question answered. You're welcome. You're welcome. It's always a great idea to go over ECG diagnosis, Dr. Aherne. So thank you for reviewing this for me again. Really appreciate it. It doesn't look like we have any questions so far. Guys, if you think of any questions in the near future, feel free to reach out to NSFEX and we can, with the permission of Dr. Aherne. Oh, looks like we have a question. So for chronic treatment of ventricular or supraventricular tachycardias, what sort of follow-up monitoring or timelines do you recommend?
So that's a really good question. I guess ultimately it depends on one, how stable the patient is to begin with. So sometimes, you know, if we have boxers with ventricular tachycardias, you know, those stable ones that don't present collapsed or anything like that, they just seem to be an incidental finding at the clinic where you hear this arrhythmia. You might end up doing a Holter monitor before you even start medications on them. And then we'll usually start medications. I'd usually recommend to follow up with a Holter monitor, usually about a month later, and see that we have a sufficient response on Holter monitor. And if not, we'll have to adjust medications. And if everything's stable, then I'd probably recheck a Holter, usually every 4 to 6 months in those patients. Again, depending on how stable they are, kind of every 6 months. Whereas if we have like some really, you know, severely affected dogs who are, you know, we end up having to hospitalize them, give them all the IV drugs, then we'll probably transition them to oral drugs in the hospital. Then we'll usually recheck them within about 2 weeks. and then kind of go down the same route of, then doing a Holter monitor, seeing if we need to adjust doses of medications, and then if stable, then kind of every 4 to 6 months for follow-up Holter monitors, and obviously rechecking sooner if there's any decompensation. Similarly with atrial fibrillation, because we're mainly worried about getting the overall rate controlled, then those guys will usually start on medications, and then after several weeks on medications, we'll usually recommend doing a Holter monitor at home to get the average rate over 24-hour period. And if we ideally want that to be less than 150 beats per minute, average over 24 hours, with an ideal goal of being less than 125 beats per minute. That's been shown to be associated with better survival. And if we can, get to those rates, then we would just follow up kind of every 6 months or so in those patients. But obviously any patient we'd need to recheck sooner if there's any decompensations. And then I see there's a question if patients with atrial standstill are also at risk of sudden death, like patients with third-degree AV block. And yes, they are at risk as well. Oftentimes, they will present with fairly severe signs of congestive failure as well, because their atria are just doing nothing. So they often present with congestive signs, and then we'll identify the atrial standstill. But they certainly are high risk and would be viewed as being more emergent for pacemakers, as opposed to dogs with sinus node dysfunction and sick sinus syndrome. Those dogs have a much lower risk for sudden death. So often those dogs are done more so on an elective basis if we're going to place a pacemaker. And usually we're only going to place it for sick sinus syndrome if there are clinical signs there. So that's the big difference between third-degree AV block and atrial standstill versus sinus node dysfunction and sick sinus syndrome.
Great. That's awesome. Thank you so much, Dr. Aherne, for taking the time out to talk to us this evening. Guys, if you have any more questions, feel free to reach out to NSVEX, and we'll try to get your questions sent over to Dr. Aherne to get a response to you shortly. So have a good night, everybody. Thank you so much, Dr. Aherne. Good night.
Thank you very much, Curtis. Thank you, everybody, for attending, and hope you all have a great evening.
Awesome.